Hello. Today I want to discuss type 2 diabetes and the possibility of remission. My last couple of lives have been a little heavy, had some heavy topics. And so I wanted to give some hope today. And that's why I chose this as my discussion. So type 2 diabetes, the study that I'm looking at, it's called What Predicts Drug-Free Type 2 Diabetes Remission. And this is insight from an 8-year general practice service evaluation of lower carbohydrate diets with weight loss. This article was published just recently in January of 2023, so it is very recent. It is a paper synopsis of a practice that is in the UK. The doctor is Dr. David Unwin. He's very popular and well known within the low carb circle, being one of the big founders and proponent of the low carb movement. And what he did is he took 8 years of data from his personal practice and compiled it and published it for others to see so they could see what the possibility was, specifically what the possibilities are in relation to type 2 diabetes remission and improvement. So, like I said, this is a primary care practice in the UK. Now, in the UK and US is different in our practices a little bit. They have some national health care funding, we're private pay funding, things like that. But I think the information in here is still very relatable to type 2 diabetes in general. So these patients, all of them had type 2 diabetes, and they were taken from his practice from the year 2013 to the year 2021. They had several interventions that they noticed in the study, and this is basically from his practice. So in general, the type 2 diabetics in this review, I'm going to call it the review, had 3 10-minute one-on-one conversations with their PCP, which is not very much different than the care we have here in the US. In general, my diabetic patients, when I'm doing a primary care visit, get 3 to 4 chronic care diabetes visits within a year's term, and they last somewhere between 10 to 15 minutes generally each. So that is very similar to the care that I give and the other primary caregivers give here. That doesn't mean I spend 10 to 15 minutes total on the visit. It's 10 to 15 minutes of face-to-face time, and then there's extra time when I am charting and following up on labs and things like that. Their patients were also offered an optional 90-minute group class every 6 weeks. So it was a group class that came in and met with sometimes the providers, sometimes support staff, that they were taught things like cooking classes, meal prep, grocery shopping, and then had other general support that was there. At their office visits, they were given 2 bits of information or 2 take-home things of information. One was a low-carb diet sheet. So basically a sheet explaining what the low-carb diet is, the basics of it. I have something similar that I give here in our practice. And another sheet, they called it the glycemic load sheet. Basically, it had a list of foods and what its glycemic load was, or how the sugar in that, the carbohydrate in that would affect the sugars, and then what were alternatives or swap outs that they could that would be a lower glycemic. So at these appointments, these 3 10-minute appointments, the primary care would offer advice on a low carb diet. And what they found, or what they did, how they approached it, is they started with weight, because weight is a metric that is taken, or a measurement that's taken every time you go to the primary care doctor's visit, or it should be. And what they did is they would say things like, your weight falls within this category, this body mass index, this level of overweight, obesity, whatnot. They would discuss low carb as an option for weight reduction. They would also discuss low carb in relation to how it could affect sugars. And similar to what we do here in our office. So say you eat this food, you eat these foods turn to sugars. Sugar then stimulates insulin. That process down the road leads to weight gain. They also talked about every glucose excursion, or every time outside the normal range of glucose, causes damage. And that is very true. Every time that the blood sugar goes outside of that normal range, it can do damage to the body. I explain it something like you have a garden hose and it's got water flowing through it. So imagine your vein is the garden hose. It's got blood flowing through it. Same premise. As long as everything is smooth and flowing, there's no damage to the vein. But now imagine that same garden hose with water flowing through it and shards of glass running through and mixed in with the water, and what those shards of glass are doing to the inside of that garden hose. Well, that's basically what's happening inside your vein when you have high elevated sugar. Those sugar molecules are sharp and they're nicking up and they're causing damage to the inside of the veins. So I don't know that they used the garden hose explanation. That's my personal explanation, but they offered an explanation and how the pathology is, how each glucose excursion matters, and how using a low carb approach normalizes blood sugar, stabilizes blood sugar, and gives you more time in that normal curve. So let's start with a couple definitions. So we use a test called hemoglobin A1C, or HbA1c. And it's a correlation to your average blood sugars over a 3-month time period. Anything above 6.5 is considered diabetic. To achieve diabetes remission, you need to be under 6.4. So under 6.4 is remission, and that's usually achieved for over 3 months of a time. And above 6.5 is diabetic. So keep that in mind when we're talking through what remission looks like in Dr. Unwin's practice. In this article, they went through several things that they noticed, highlights, how they started in 2013 with addressing the weight, and then how their practice evolved from there. So they made note of how things have evolved over time. The first happened very early in 2013, and they noticed a trend that when someone initially started a low carbohydrate diet and saw success, they saw improvement, that it seemed to fizzle out or fade or not do as well. And so they quickly realized that they needed to change some of their tactics after the first visit where they introduced low carb intervention and someone starts working on it. They realized, all right, we need to start having a conversation that looks ahead in the future. So if we are in the month of, say, April or May, we need to start talking about vacation and how we're going to stay on track on vacation. If we're in June, maybe we need to be talking about the 4th of July and what that looks like. Or if we're in October, how are we going to handle Halloween candy? Or how are we going to handle the holidays? And I completely relate to this. This is something that in my primary care practice, and especially in my weight management practice, we're always looking that next step ahead, because if you don't prepare for those things, they're going to happen and you're going to get off track. So they quickly learned that they had to always start looking a step ahead and prepare to keep people on track so that they didn't lose focus on their intervention. They also found that sometimes a quick phone call, if they noticed someone's sugar was trending up, a quick phone call during that time would say, hey, I noticed you got off track. It's time to refocus. And that would kind of bring people back in. Somewhere around 2016, they noticed that several of their clients were having weight regain. And they took a step back, they looked at their population, and what they found was the likelihood of food addiction, something else we've been talking a lot about here, and we're going to continue conversations with. I've got some specialists coming up that we're going to talk with about it, but food addiction and addressing that. And so they had to change the conversation to relating certain foods to essentially drugs and alcohol, and how we respond similar to these foods as we do drugs and alcohol, and how the intervention is now changed to, all right, let's find our triggers, and we have to avoid those triggers. And some of those are actual trigger foods. Like for me, Baby Ruth and Snicker are forever off the table, not just because they have sugar, but because I can't eat just one. So those foods are off the table at trigger foods for me. You probably have your own trigger foods. Also trigger environments. If you have certain restaurants, I have a patient that was not able to go to buffets or restaurants that offer buffets anymore because the buffet always put that person off track. They could go to other type restaurants where they're ordering an individual meal, but not the buffet type one. You may need to avoid the donut shop, even if it's your favorite coffee, because if you go in there, you're going to be triggered to eat the donut. So it's situations and foods that could be triggers, and how to avoid those to address the food addiction. They found next, a couple years down the road, that hope was a big part of this too. And I can very much see how that happens. So when an individual loses hope that they're going to get better, hope that there's going to be an end result that's going to be positive, hope that they're going to make any progress, hope that they're not going to fall off the wagon again. When they lose hope, they tend to start regaining weight and their sugars started going in the negative direction. So they started including interventions to help foster hope. And one of the main ones of those in these short little time windows that the primary care would get with the individual was to focus on realistic next steps. So not our big overall goal, but what is the next one? What is the next thing that we're going to work on? Is it hitting a certain protein goal in a day? Is it removing a particular item? Is it avoiding that particular place? Is it walking 2 days a week? What is the realistic next step for you, no matter how small that next step is? And each of those steps grew to build hope. Lastly, they found that they had to consider how an individual learned best, because we all have individual learning styles. And within their diabetes program, they found that the individual either learned best through handouts, books, or apps, and they tried to foster or get them the resources they need. Now, here in our weight loss practice, we do all three. You get what I call the Amanda Bible, which is a blue booklet that is put together that gives you a full synopsis of handouts and resources and things. In that, there's a list of books that I highly recommend. One is End Your Carb Confusion by Dr. Eric Westman's one of the ones I recommend to most of my patients. And then now we have the DMA Weight and Wellness app that helps to guide and give support through people's journeys too. So we just give all three and people use what they need to use in their practice. They try to find which one works best for them and tailor to that. So over this 8-year period, they had 473 type 2 diabetics. And of those 473, they all were offered low carb diets as an option to control their diabetes and to help with weight loss. And 186 chose the low carb approach. They didn't force it on anybody. They said, this is an option. You can continue your traditional care, or we can go in and try this low carb thing. So 186 tried the low carb thing. In that group, 61% was male, so it was a little bit heavier slighted towards the male population, and they had an average age of 63. Most of them kept follow-up for 27 months or a little over 2 years. Time was the amount of time they had follow-up. And in this group of 186 people, around 37.6% were in the first year of their diabetes diagnosis, which is going to be an important thing here in just a little bit. So when you looked at this whole group of 186 people that chose the low carb lifestyle, the average weight loss in that was 22 pounds. Pretty good. Their average A1C was started at 7.9. So you took everybody's highs and lows, and they were 7.9. Remember, above 6.4 or 6.5 is diabetes. So 7.9, and most of the average at the end of this 8 years was 6.4, which is the remission part that we looked at. Triglycerides, which closely relate to diabetes, they also saw about a 62-point drop, which is pretty significant. They also saw a decrease in blood pressure and total cholesterol, which most people have the misconception that total cholesterol is always going to increase on an LDL diet, and that, or not on an LDL diet, on a low carb diet. That's not always the truth. LDL didn't really change that much in his study. And HDL, the protective cholesterol, increased overall. Now, if you take and look at the people who achieved remission, so those that got their A1C under 6.4 and those that did not achieve remission, the remission group lost more weight than the non-remission group. So those that achieved remission overall lost more weight. That was a finding that they found. However, the non-remission group had a greater reduction in their A1C, their average sugars. Now, in fairness, the people that didn't reach remission but had a larger A1C drop started with a much higher A1C than the others that achieved remission. For example, the remission group, the average A1C, those that were able to get rid of their diabetes or put in remission, their A1C started at around 7.1. And those that didn't quite reach remission, their A1C started at 9. But overall, everybody's A1C improved. So what they found was that the remission group was more likely to have had a recent diagnosis, to be 1 year or less into that diagnosis of diabetes. And they started with a lower baseline A1C. But all other metrics were the same. So age was roughly about the same, starting weight was roughly about the same, blood pressure was about the same, cholesterol was about the same. There really was no significant difference in the other metrics. other than they had a younger diabetes years, and also they started with a lower baseline A1C. Those starting with a higher A1C were more likely to have that larger drop, and I think that's because they had more room for improvement. Basically, they didn't achieve remission, they didn't get rid of their diabetes, but they had huge and significant improvements, but they had much bigger room to improve. Over 8 years time, of those that chose to do low carb, 51% achieved remission. That's pretty big. So for all those 186 people, 51% of them were able to say, I no longer have diabetes right now. Now, I guess there's that difference between remission and reversal. I don't know how I like to think of it. I do think diabetes can be reversed, but remission, I kind of like that thought too, because when you think of yourself as being in remission from a chronic condition, you're more likely to consider your lifestyle as your treatment. So your food is your medicine. Your food is what is keeping you under control. And if you go back, just like if you stop taking your drugs for other things, it goes back. Well, if you stop eating that certain way, you're going to go back. So remission, to me, it has a better mental way of helping someone stay on track. So I like the word remission, I guess. So what the cool thing about this 51% of it accounted for 20% of that particular primary care's practice of diabetics. So of the ones that chose it, 51% achieved remission. But of all of the diabetics in his practice, 20% received remission. If every primary care provider had this same result, if all of us had 20% remission of type 2 diabetics, can you imagine the impact that would have, locally and globally on our diabetes risk for the future, on our current burden to the healthcare environment? That's pretty huge. And it also should be encouraging that we can take a dietary intervention, not a medicine intervention, a dietary intervention, and essentially reduce the burden by 20%. And remember, this was off of just people that chose to do this. If all 473 people in his practice had attempted this, and 51% of those people achieve remission, and 20% of, man, that could be so much bigger, so much bigger. So that brings hope to me to know that we have the power to improve our personal health care, the healthcare of our community, and the health of our basically nations, because our chronic conditions are draining our nations right now. All right, so weight loss. All participants that achieved remission had weight loss, and that was a common thing, that those that did not lose weight did not achieve remission. Now, what was cool is there were 2 patients that only lost about 2 pounds, and that's not a significant, huge amount of weight. So it's not directly the weight loss that is causing the reversal of the diabetes. It is the diet that is causing it, and the diet is also causing some weight loss. Now, we do know that weight loss itself and other diets can help to reverse or put diabetes into remission. We've seen this with gastric bypass, which is, in my opinion, it's actually very low calorie and very low carb, because it cuts so much, and they are protein focused after the diet. But we see diabetes rapidly reversed in that condition. And so it's not all about the weight loss. Weight loss can cause it, but also the diet itself with minimal weight loss causes improvement of glucose and sugars. So they found there were several predictors of success. So they looked at the people who achieved remission and what were the predictors, what things could predict which patient was going to achieve remission and which patient wasn't going to achieve remission. So one, they found that predictors of success across the board for improvement was that the intervention was provided by a trusted professional. It was their doctor, it was their nurses in the clinic, it was the nutritionist in the clinic, it was their trusted people that they knew and that they cared for and they knew cared for them, that were delivering this and taking time. So it wasn't some random internet person, it was someone they had a relationship with, and they found that was very important. They also said it was very important that that provider have a very frank discussion. So don't sugarcoat it. This is what it is, cut and dry. And they knew that that was coming from a point of concern and not a point of shaming for fat shaming or something of that nature. It was truly a point of concern. Ongoing support is important. And I want to take a moment to reiterate this one, because we have our first 12 weeks of the weight loss program and people tend to do good, and then they somewhat fall off after that. And what I've noticed is when people start missing appointments, when we say, all right, come back in 2 months, and we actually see you in 4 to 6 months, they are more likely to get off track. So that ongoing support, the ongoing connection is extremely important in the remission of type 2 diabetes, but it's also extremely important in remission of your weight when you lose weight. Addressing food addiction, that's huge. That is something I 100% agree with. If we don't address food addiction and start to figure out ways to cut processed foods and eliminate them, we're kind of hopeless against the weight and diabetes. Monitor and correcting for carb creep early. So if you've never heard the word carb creep, you've probably seen it. So if you've been on a low carb diet and you think everything's going well, you've been cruising along, losing weight, and then all of a sudden you start seeing your weight go up. I've seen this in my own life. And when I step back and look, all right, a bite here and a bite here and a bite here and a bite there and a bite over there. And all those bites add up. That's called carb creep. And that is one of the number one causes for weight regain or cessation of weight loss, and also for seeing sugars go back up after we've seen an improvement. So they found that it was important to monitor for carb creep early. So frequently checking in, checking yourself, double checking, make sure you haven't added things back to your diet that need to stay out of your diet, and then early intervention. Anticipating the challenges, so looking ahead for those holidays and events, birthdays, stuff like that, anticipate those, learn from them, but then learn from failures too. So when you do have that event that gets you off track, instead of beating yourself up and living in the dump and the woe is me and just staying off track and living in a bad place, ask yourself, what would have made that situation different? What can I do different next time? Because guess what? Life is full of dramas, traumas, whatevers, llamas. I like that one. But life is full of those, and they're going to keep coming back up. So what can you do different to next time not end up in that same situation that you're in this one? And then fostering hope. So those were predictors of success, not just remission, but improvement, success, all that kind of stuff. What predicted remission was the less time you were diabetic. So if you find out you're diabetic, you got this certain sweet spot that is the best time for you to potentially achieve remission. And that's the first year to 2, but really the first year is the best. That is your best opportunity. Now, I've seen people outside that first year reverse or put their diabetes in remission. I've seen it multiple times, but in the study, and by and large, that first year is the sweet spot and is your best chance at reversing and putting your diabetes in remission. The lower your A1C is when you start. So if you start your diabetes journey with an A1C of 7, that's your best time to jump on it, because every point you go up, the harder it is to reverse your diabetes. If you achieve weight loss through a low carb diet, then that was a better indicator of remission. So one stat they said is, of those that chose the low carb diet, 77% opting for the diet within the first year of diagnosis of diabetes achieved remission. So going back to that whole 1 year in, 77% of those within that first year achieved that remission. It didn't clearly say about the other people that were in that first year. My suspicion is that their A1C was much higher to start with. So maybe they were further on in the disease before they achieved their diagnosis and could intervene, but it didn't really say. So what about for those people that are over a year out? What hope do you have? So although the remission rates are lower in this group, in this particular article, they did see that your condition was greatly improved. Your diabetes was much improved. You're on way less medications. You may not be able to say that it's gone. You may still have that diagnosis, but it was much better, and you were on less drugs, and you were minimizing your risk for other health complications down the road. One of the benefits that this study being done in the UK is that universal healthcare that they have there. So they have the ability to look at the amount of drugs that their practice prescribes compares to the next doctor, because all that data is kept. So when they looked at the medications they prescribe versus a similar GP practice in the same area, yearly, they saved $74,383 in diabetes medications, not even the high blood pressure, high cholesterol, things like that, just in diabetes medicine. So there again, if every GP did that, if every GP had reversal of 20% of their practice, if every GP had essentially $75,000 reduction in medicine, how does that compound over the course? And what does that do for the financial future of your country? It's a lot. It's a lot. So it was a great study. I've got the article linked there. Go read it, get some hope for yourself, forward it on to people who have diabetes and let them see for themselves that diabetes is possible to put in remission. We have documented cases. Like I said, we've seen it here in our clinic. I'd like to reiterate that our weight program is very similar to what the intervention's done here and can help with diabetes reversal. We also do a diabetes remote patient monitoring program that also has the app connection and connection with us. And we're starting to see people improve their diabetes, and hopefully some of them will achieve remission or at least great improvals. We're already seeing the improvals. If you are part of Dixon Medical Associates, or you know someone that's part of Dixon Medical Associates and has diabetes and would like to consider joining our diabetes remote patient monitoring program to learn about the low carb lifestyle and how that can affect your sugars, and to have a provider right there with you doing it hand in hand, give our office a call or have your provider send us a referral over for the diabetes program. We would love to have you, love to help you. So I hope you have found some hope in this study and know someone that you can forward it to. And I look forward to our next conversation.